is an excellent rheumatologist from Tamil, India, and is teaching in the special areas of interest. So, take as arthritis, Sjögren's syndrome, lupus, and infection-related rheumatism, and heading a large department in the most prestigious tertiary care teaching hospitals in India. Dr. Debashri Danda, we are so happy to have you here.
Welcome, Dr. Debashish Danda, to Pakistan Society for Rheumatology. We are so happy to have you, even if it is virtual, it means a lot to us. I would request you now to share your screen and start your presentation. The audience is waiting for you to start your presentation. Thank you. Can you hear us, Dr. Danda?
Yes, I can hear.
Yes, thank you.
I'm just sharing the slide.
Okay, thank you.
Is it visible, my slides?
We can see your slides and we can see you as well.
Okay, thank you. So, should I start?
Yes, please.
Thank you. Thank you, Dr. Saira, Dr. Nikat, Dr. Sumaira, Dr. Ahmed, and all the friends from PSR. It's really a great opportunity to share with you a little bit in your Congress. I'm fortunate that this is my first opportunity probably to share experience in our center. So, Salam alaikum to everybody. I'll move on to the slide. I've decided to share with you some of our own data, a little bit from others also, on some uniqueness of autoimmune rheumatic diseases in our zone or South Asia. So we know that South Asia are actually speaking mostly very homogeneous population divided by borders. So this is my founder of our institution, Dr. Ida Skada, who came as a missionary 122 years back to establish this hospital, which started like a bullock cart, and today it is a almost 4,000 bedded hospital in five or six campuses now. And this is very close to Chennai, between Chennai and Bangalore. So I will be sharing with you some of our data which we have published based on our population. And I must tell you that our patients come from all across South Asia. Earlier, we used to get even patients from Afghanistan and Pakistan, but now it is little less from that area. But I must emphasize that we have quite similarity with quite a bit of similarity with your population, as you understand. So I'll start with a few work on spondyloarthritis. I'll cover mostly on SPA, psoriatic arthritis, lupus, Sjogren's, a little bit of antiphospholipid syndrome, autoinflammatory. So this is we have been talking because of our socioeconomic background, not that everybody can afford biologics. And the Western data says that if a spa, axial spa fails on NSAID, you go straight to biologics. And they feel that the methotrexate and sulfasalazine is not working. Actually, if you see the Cochrane reviews, they are inadequately designed and they are not uh, powered enough to come to such conclusions. So we did this cohort study, and we actually found that, even after 6 months to 1 year follow-up, we had almost 60% patients doing well on sulfasalazine and methotrexate in terms of BAS-DI and BAS-5 even. So this was done in a very delicate balance of designing, where we had done propensity scoring for baseline parameters, which makes it almost close to an RCT. And this was published. And this was the design of the study. And you can see 3 months and 6 months data, and looked at pure axial as well as axial with peripheral arthritis. So you can see that pure axial also did pretty well, almost as good as those with peripheral arthritis, unlike what is told in literature. Now, in psoriatic arthritis, I would like to share that this was our study some couple of years back, where we looked at in psoriasis patients without clinical arthritis and looked at the feet MRI, and we actually found that early arthritis for psoriasis screening questionnaire score of more than 3 was significantly associated with amazing features of inflammation in the pure psoriatic group. PSO is the psoriatic group, PS is the psoriatic arthritis group. So this was not too less compared to those who had florid or open clinical arthritis. So this is showing the changes in MRI and axial sequence, synovitis of first and fourth MTP joints, and also axial sequence showing tenosynovitis, and STIR sequence and 3D-T1 sequence, respectively, showing osteitis. So if you see the percentage of synovitis, people with only psoriasis without any clinical arthritis, almost one-fourth of them had subclinical synovitis picked up by MRI, compared to 50% in those with clinical arthritis. So proportion of patients with MRI inflammation overall, including tenosynovitis and osteitis, is almost one-third. And whereas proportion of patients with MRI inflammation involving synovitis, tenosynovitis, and osteitis in those with psoriatic arthritis is 50%. So this is not too bad, and then it means that there is clinical synovitis in many. Now, we have this. Uh, I would like to share with you one of my clinical observation of my lifetime career. As early as 1996, 97, we observed that the disproportionate swelling of the IP joint of the thumb is seen in almost 25, 30 to 35% of psoriatic arthritis patients. And this can be a very unique feature of psoriatic arthritis, where you have no other clinical feature of psoriatic arthritis, but just a disproportionate IP joint of the thumb swelling. And this we published in an Indian Journal of Rheumatology in 1998, 99. And then this time recently we did an MRI study, and this MRI study shows the risk ratio of MRI global inflammation at the IP joint of the thumb. Mind you, this is not dactylitis. This is pure IP joint of the thumb arthritis in psoriatic patients, and it has a 2.3 odds ratio. Mm, when you compare to rheumatoid arthritis, and when you compare to undifferentiated inflammatory arthritis, it has an odds ratio of 2. So presence of IP joint of thumb swelling is an independent predictor of of uh, of psoriatic arthritis, and it differentiates from undifferentiated arthritis and rheumatoid significantly. And the MRI inflammation around the IP joint of thumb was significantly more common in patients with psoriatic arthritis as compared to individuals with undifferentiated arthritis. So this is something I feel very dear to my heart and clinical observation. And so, if you what I said about the clinical features, you see this thumb here. So, if you see this is the IP joint swelling. There is no dactylitis here, but there is IP joint swelling here also. You can see. Sorry for the dark image. And
recording in progress.
So the dactylitis is not there. It is just IP joint of thumb swelling, and it shows the same thing was documented. You can see the synovitis documented in the MRI here. So so this was a star image which showed the IP joint of thumb swelling, psoriatic, and you will, if you observe in your clinic from today, you will find many patients like that. So, and also we did a publication that one of the characteristic features where the psoriatic arthritis can be differentiated from rheumatoid in ultrasound is the presence of MCP joint. So the absence of MCP synovitis is got a very high predictive value for psoriatic arthritis. So if you have no MCP synovitis in high resolution ultrasound, it basically favors the diagnosis of psoriatic arthritis, whereas if it is present, it favors the diagnosis of rheumatoid arthritis. And I'll go to a few papers on lupus, a few interesting in our from our center. So we actually
Dr. Debarshish will be joining us within a minute.
Dr. Danda's connection has said we have just lost his connection, but he is rejoining. Something that is common in both our countries is that we have power outages. So he will rejoin in just a couple of minutes.